So because this athlete is a soccer goalie, I give the scenario: a soccer goalie comes into the athletic training room complaining of pain at her head. So the injury is a head injury, and it's on the temporal right side of their head, right in here. And it happened, we're on the field in an in-game scenario, because the goalie was diving to her side to make a save off of from a volley off of a corner, and then she got pushed midair, and her head came in contact with the goalpost on the right side. She has no previous medical history of concussions or injuries related to the face other than her just a couple of nosebleeds. So we'd go out to the field, and she'd be laying on the ground. Observe that she's in a lot of pain, and she's not really willing to move a lot of her body. So I'd stabilize her head, like right at the neck, like this. Assess where she got hit for any bleeding. I do notice bleeding, so immediately grab, I'm wearing gloves, obviously, and then grab some gauze and put the gauze directly onto the incision. It's important not to try to clean any of the skull injuries or open wounds right away, or make sure anything's in there. So I just cover it. I apply pressure while I'm looking at the rest of the head. So one hand is applying pressure, or if somebody was there to help me, I'd have them apply the pressure while I looked at the rest of her head. I did notice that the swelling is starting to increase really quickly. So you could feel that there's not a normal contour of the head. And you can see the incision. So I cover it up, and then she's not going to do any range of motion because it's contraindicated due to the fracture, and it's at the skull. But we also wouldn't want to have her move her spine, so I'd be palpating the spine. An important thing to look for when the fracture with a suspected fracture would be a suspected C-spine fracture. So I'd palpate like this all the way up from C2 down the spinous processes is C7, making sure I'm covering the transverse processes too on the outside. And then I'd ask her if she were to remember anything what happened, if she was where she was now, if she had any headache or blurred vision or anything immediately to check. I'd check her pulse, her respiration rate, obviously, and if any of her teammates or anybody saw her go unconscious for that period of time. And then manual muscle testing would be contraindicated as well. After I didn't suspect a direct C-spine injury, I might I'd move her C-spine a little bit just to see if any of those motions were to become irritated or cause pain. Even though she's not going to be really wanting to move it, I'd need to rule it out just to help myself with that. Then another thing we could do is grab a gauze pad and then stick it in her ear for the halo test. That's one of the only ones that'll help rule in a skull fracture if she had the cerebral spinal fluid visible on the gauze pad. It'd be like a yellowish kind of color, so I'd do that. Or someone with me would help do it while I was at the C-spine. And then while she was on the ground or anything, I'd make sure that she wasn't having any immediate visual impairments or problems, and then try to sit her up and get her to the sideline, where then I would probably have more of control over the bleeding. So I'd wrap the head a little bit and then I do a cranial nerve assessment. So hold my finger out to look at vision and run through the cranial nerve. So it'd be out, and I'd go to the lateral side, making sure she follows it all the way to the end without moving her head. And then back in, all the way back. We'd go up, and then go back, and then go down, and then up diagonal right, and then down diagonal left, and then up diagonal left, and down diagonal right. I'd cover one eye and then shine the light to see the pupil dilation. So I'd go to this side, and then I'd repeat, and then shine on this side and look for the reaction with the pupil for that. I'd ask her if she smelled anything out of the ordinary, or could smell anything, or had a funky taste in her mouth, to do that. And then cranial nerve 12, I'd ask her to stick out her tongue and say ah, like that. And then clenching the jaw for the mastication for cranial nerve 5. And then I'd ask her to swallow to see if she had function of her larynx, and that would cover cranial nerve 10 and 9, 10, 9 and 10. So once she had a cranial nerve assessment, then we'd look at this point, probably going to refer immediately to a physician. That's what you'd want to do. But then also once they ruled out, or like covered up the head and dressed the wound, a concussion would be the next thing to rule out, or a traumatic brain injury, because it'll probably coincide with the fracture, or it may not be there at all. So running through, like having the patient run through a SCAT 5 would be good when they return. You don't necessarily need to do it now because the skull fracture is the priority, so you'd want to ship them out. But once they return, thinking about the return to play protocol with a concussion, if they had a physician look for a concussion after they were referred, and then that would be it.